Hello, good evening. Welcome to the third webinar of the webinar series conducted by the Faculty of Critical Care Medicine of the College of Anesthesiologists and Intensivists of Sri Lanka. On behalf of the College of Anesthesiologists, the President, who is busy working in an COVID ICU these days, I would like to welcome our speakers and participants and all of the sponsors and everybody who is helping to conduct this webinar as a successful event. I'm going to introduce you to our first speaker, and I must say I am very proud to introduce Professor Suranjit Seneviratne. He's a professor and consultant in critical care medicine, Professor Suranjit Seneviratne is a consultant in clinical immunology and allergy at the Institute of Immunity, Transplantation and Clinical Services at London, UK. So he is one of the local products, having graduated from the University of Colombo. I can remember Suranjit as a young, attractive, smart, enthusiastic young doctor way back in late 1990s. So he had proceeded to UK, completed his MD as in internal medicine and went on to study immunology and obtained his PhD in University of Oxford. He has numerous publications to his credit in peer-reviewed and index journals. I will now invite Professor Suranjit Seneviratne to his talk on management of cytokine storm in COVID-19, the role of extracorporeal therapies. Today, the main webinar is on extracorporeal therapies and its role in management of cytokine storm in COVID-19. Over to you, Suranjit.
Thank you very much, Vinodini. I'll share my slides now. Just a minute. So, tell me if that is coming. Put on presentation mode, just a minute. Yeah. You can.
Yes, perfect, Suranjit.
Excellent. Okay. So what I'll do now is talk to you on some I can get a echo coming. So I'll talk to you on some aspects of COVID-19 and the cytokine storm. And all of you, I will take it from the baseline, from the sort of first principles. All of you would know this diagram very, very well. The spike protein on the surface, the envelope and membrane proteins, the RNA virus, and the nuclear protein. This is the virus that has caused so many problems during the last 17 months or so. And it binds to the surface of the cell, to the ACE receptor, enters the cell, multiplies, or what we call replicates. So, and then it spreads from cell to cell and person to person. And this is the one that has been causing all the devastation so far. Now, our immune system is there to be able to defend against viruses, bacteria, and fungi, and other danger signals. You have the innate immune system, you have the adaptive immune system. The innate is the first, like the army, the first responders to any danger. And then the adaptive consists of antibodies and certain types of white cells, especially lymphocytes. And then you have complement. Basically, it just complements the the antibodies and white cells do. And cytokines come in there. Cytokines are chemicals that the immune system uses to talk to each other. We use language, English, Sinhala, etc., Tamil. they use cytokines and chemokines. And that is an important thing to remember. A certain amount of cytokines are important, but too much of cytokines, especially if it's inflammatory, can be not good and can be harmful. So if we look at the innate immune system, there are two important cells, the neutrophils and macrophages. They produce a lot of chemicals, and the neutrophils have certain nets, etc., and they're very vital. But if they overact, then the problem occurs, and the patients with severe COVID go into leak in fluid, etc., and there have been lung involvement and significant symptoms. So these are the two important innate cells, the neutrophil and the macrophage, and they produce a whole range of cytokines, including other cells like mast cells, etc. Then I said there are lymphocytes. There are T cells, there are B cells. T cells are CD4 cells, CD8 cells, and they do different function. B cells become plasma cells and produce antibodies. So those are the basic sort of adaptive immune cell, antibodies, and the CD4 and CD8 cells. And you have the CD4 cells, helper cells, CD8 cells, the killer cell, and B cells become plasma cells and producing antibodies. And they talk to each other using these different chemicals, etc. Some are inflammatory cytokines or pro-inflammatory, some are anti-inflammatory cytokines, and different cytokines are produced. So what is a cytokine? You have a signal coming to a cell, the cytokine producing cell, it produces cytokine, it binds to a receptor, the receptor sends a signal to the nucleus of another cell or the same cell, and then you have the effect. And that is an important signaling process. We do not want excessive amounts. We want just the right amount. We don't want too little too. We want just the right amount. There are different cytokines and chemokines. Interleukin 1, interleukin 2, 6, 9, 10, interferon gamma, TNF-alpha, you name it, we have a lot of cytokines that are circulating around. And it differentiates into Th1 cytokine, Th2 cytokines based on the sort of cell that is produced. If it's IL-4, IL-5, IL-13, that is the allergy cytokines. And then if it's interferon gamma, etc., it is more of the Th1 cytokines. So I won't go into too much detail there, but importantly, remember IL-6, TNF-alpha, etc. So what are the immune changes in SARS-CoV-2 infection, that is the viral infection, which leads to COVID? You have certain cells increasing, like neutrophils, macrophages. You have certain cells reducing, like the lymphocytes, T lymphocytes. You have increased amounts of chemicals, like the cytokines. And in certain instances, it can lead to a hyper-inflammatory state that is pro-inflammatory cytokine. That is not too good. Now let us look at this schematic. Normally when a virus comes into our body, the virus multiplies and then it comes down because the immune system comes into action. And then in green is the innate immune system. I told you the first part of the immune system. And then you have the T cells and antibodies. And this is a normal, if you get a cold virus, etc. This is what happens normally. What happens in SARS-CoV-2 infection or COVID, especially severe COVID? These are the severe COVID. Look at the green line. It's not a nice early signal. So the innate immune system is delayed. It is dysregulated. This is what the virus uses to get rid of the, to overcome the immune system, the innate immune system, the first responder. They try to do something to confuse the immune system. So you can see it is really dysregulated, then it overacts. You can see the rapid increase in the green line, and that is overactivity of the innate immune system with a lot of cytokines, IL-6, TNF, etc. Antibodies increase, but T cells are so weak. So this is a central tenet to be remembered in patients with severe COVID. The group that goes into ITU that you all will be looking after have this problem in the innate immune system, then overaction, and then you have problems with the T cells. They are not functioning properly. So what happens here when you have the infection? Either you can, there is lung epithelial involvement, gut epithelial involvement, and then a number of cells are recruited. Those produce cytokines. Some cytokines are fine. They will cause a reduction in the disease. Some cytokines are pro-inflammatory, and they will cause an exacerbation with symptoms. And that is the spectrum you would see, and where these other treatment options are coming into play. So remember, in patients with severe COVID, you have a lymphopenia and a transient immunosuppression. We have to remember that, right? There's a lymphopenia. And there is the hyperinflammatory component with cytokines. So there are two ends of the spectrum you have to deal with. And that is why with the lymphopenia, when there's a transient immunosuppression, you have to be careful with secondary bacterial infections, fungal infections, etc. Hypercytokinemia could lead to the increased organ effects on the lung, on the liver, on the kidney, on the heart, etc. And that is something you have to look into and prevent it occurring, because otherwise the virus will go down, but you will be losing the patient because there is an overactivity of the immune system, and that again is not to us. So the immune system has to be in the correct bandwidth. It should not be too little, it should not be too much. So if you look at a respiratory infection, what happens? A number of cells come in, innate immune cells, they produce cytokines, and I've listed the cytokines in that slide, and I've highlighted the important cytokines called IL-6. That's very important, but there are lots of other cytokines that are involved there. IL-6 has a whole range of actions. It has a major plethora of action, including fever. This cytokine you get when you get a common cold, etc. We know you wait on bed, etc., with body aches and pains, etc. So a whole range, and CRP increases. This is one thing we monitor with regards to severe COVID patient, the oxygen saturation and CRP. So what happens in COVID-19? You have inflammatory signals, number of cells come in, then you have this cytokine storm developing in a certain proportion of the patients. And that can lead to multiple organ failure, hyperinflammatory state, and final death if you don't treat it properly. So this is what happens ultimately, this hyperinflammatory state affecting a whole lot of organs, and you all are quite aware of this scenario. It starts with a viral infection, then it just goes out of control. You have seen patients with dengue before, etc., where either virus caused the damage, and then it goes into the immune overactive leptospirosis, etc. This is an important thing to be remembered. So an important thing to remember is that there are two phases. There is a primary cytokine, there's secondary cytokine, one set of cytokine, the innate immune system, I introduced it before, the first line produces cytokine, those stimulates adaptive immune cells, T cells, CD4, CD8 cell, those produce cytokines, and then this just goes like a whirlwind, and you will have to bring it under control as soon as possible or prevent it occurring. That's a very important aspect, and that's where other treatment options of taking out the cytokine comes into play. So I've told you this, there is an interaction between cells of the adaptive immune system and cells of the innate immune system. That is, the innate immune system cells produce cytokine that affect the adaptive immune cell like CD4, CD8, etc. Those cells, TH1, TH2, TH1, TH17 cells, etc. And those in turn produce cytokine, which once again affect the innate immune cells. So this cycle is the one that we really want to break, removing those cytokines, which are the messengers of the signals between cells. They are the ones who talk. If you want a lot of gossip to stop going around, you want to stop that message going across, because otherwise it can be very, very disastrous for the whole system. So this is another schematic to show this messaging that goes on between cells of the innate immune system, adaptive immune system, with more cytokines produced, and it just goes into a full sort of self-circulating process where and ultimately organ damage and the person dies if you don't try to do it. So what do we do as clinicians? We try to prevent infection, and that's how social distancing, vaccination, etc. But some will get infected. You want to early detection of the infection and look for increase the people who will deteriorate into the most severe category, the severe category where you want to prevent that cytokine storm occurring. And once it occurs, you want to manage the cytokine storm appropriately to prevent the people dying, because the death is a problem. So early on, it's social distance vaccination, but then later on, you have to treat it appropriate with antivirals, anti-cytokine treatment, etc. So if we look at this in a different schematic, you have a whole lot of cells producing cytokines. As I showed you here, there are a number of cytokines, IL-6, IL-1, TNF-alpha, etc. So can we remove it or can we neutralize it? That's what we are talking about. Very early on, or say last year, steroids came into process. Very early on in the pandemic, people said steroid should not be considered because it was published in the Lancet somewhere around February. But then after that, the recovery study came and clearly showed that dexamethasone is beneficial in this group of patients and to reduce the hyperinflammatory state. So that is one intervention. Knowing the pathogenesis allows us to treat it properly. And with the clotting coming in, anticoagulants, so that is why knowing the pathogenesis is so important. Then can we remove different cytokines? And this is where the product Cytosorb comes in. It's composed of highly biocompatible porous polymer. Each bead is roughly the size of a grain of salt, and the relevant surface of absorption, the internal surface, which absorbs the cytokine. That is important. It acts as a tiny sponge to remove substances through process of absorption. So that is another option that comes into the process in the selected correct group of patients. So what does it do? At different levels, it can, at the infection level, at the sort of damp level, and at an organ level, it has several steps that it has a role to play. And this will be gone into greater detail by the next two speakers, where I will give the pathogenesis part of the cytokine storm. Next, we have IL-6, which again, we know that in certain groups of patients, we intervene and neutralize it. And this is the way we neutralize IL-6. Either we can use antibodies against the IL-6 receptor, like tocilizumab. We can use antibodies against IL-6, or we can remove it. And that's where treatments like the removal of the cytokines come into the role, or you can neutralize it either through a receptor or through the acting on the cytokine itself. So the receptor blocking is being used at the moment. So steroids, cytokine receptor blockers or cytokine blockers, and removal of the cytokines are the three options to get rid of the hyperinflammatory state. So in summary, in my talk, what I'll mention here is you have the SARS-CoV-2 comes to the lung, comes to the gastrointestinal tract, stimulates cells, immune cells, innate immune cell. Those produce cytokines in a group of patients. Others may be asymptomatic, others will get mild infection, moderate infection, especially in the severe, it stimulates the immune cell. The immune cells will produce cytokines, which stimulate more cells. The cytokines are of a good nature. It will cause the infection to resolve and the patient will improve. If it is of a hyperinflammatory nature and there's excess amounts of it, that can lead to ITU admission, death, and other complications, organ involvement. So what are we trying to do as clinicians? We are trying to prevent it initially, the infection, social distance vaccination, trying to monitor monitor the infection and treat it with antivirals, etc. Then we're looking at the cytokine, because the immune system comes into play after that. And when the immune system starts kicking into play, if we know that it's going down, how do we do it? We neutralize it with a broad brush, such as steroids, which has been shown to be beneficial, or use cytokine or cytokine receptor blocker, or you remove it. And that's where Cytosorb comes into the equation of treatment of patients with COVID-19. Other treatment options like monoclonal antibodies, etc., come in. I haven't gone into detail here. So thank you very much. We'll stop here with this summary. Thanks.
Thank you, Professor Suranjit, for that very informative information that you have given us in a very clear format. So before moving into the second talk, there is a message for all participants. You can post your questions indicating the speaker that you want to ask the question to the question and answer box that you can hear on your screen. So we are going to move to our second talk. Our speaker is Dr. Raji Paul, MBBS MD. Dr. Paul is a senior consultant physician and a critical care specialist in one of the premier health institutes in India, that is Apollo Hospitals in Hyderabad, India. He's an associate professor to Macquarie University of Sydney, Australia as well. He has multiple publications in various fields in critical care medicine to his credit. He is going to talk to us and share with us of his real-time experience in managing cytokine storm in with using Cytosorb. So over to you, Dr. Paul, for to share your experiences with us with the Cytosorb. Over to you.
Good evening, everyone. Good evening, Dr. Vinodini, for the nice introduction. And nice work done by Professor Suranjit for explaining the immunopathology of COVID-19, which has been creating a havoc all over the globe. He has basically touched the concept of cytokine storm being the cornerstone of deterioration or the worsening of a patient and landing in multi-organ dysfunction syndrome, and ultimately fatality of the COVID-19 in many cases is secondary to the cytokine storm. So I'll be basically dealing with the cytokine storm and how do we treat it, and my personal experiences in sepsis as well as in COVID-19, what we are doing with the cytokine storm and the use of treatment modality to counter it. So as Dr. Suranjit, Professor Suranjit very clearly told that sepsis, and it includes COVID-19 also in this picture, basically is a circle of pro-inflammatory and anti-inflammatory cytokinemias. Whenever sepsis starts and goes into worsening phases with hypotension, lactatemia, and other organ dysfunctions, there is a pro-inflammatory as well as an anti-inflammatory mediators, both go on together. Pro-inflammatory like IL-6, and anti-inflammatory like IL-10. However, many of these patients show what we call as dysregulated immune response, a dysfunction immune system, in which for some unknown reason the immune system starts to overreact to the situation. It's just like a small mosquito, and it starts to get in some big guns to kill it. So there's a complete haphazard immune system working in some situations, which leads to what we call as hyperinflammation. And that is what leads to the deaths in many of the cases. The acute hyperinflammation, which generally would start if in COVID-19 from day 5 or day 6 onwards, is what is the other term which we call as a cytokine storm. This hyperinflammation, if identified on time and treated on time, we could save few patients which otherwise would land with multi-organ failure or severe lung injury, which will ultimately require ECMO or a lung transplant for survival. So we are trying to attenuate this burden of hyperinflammation by what we call as hemoadsorption, which is what Cytosorb is all about. So regarding the concept of cytokine-induced damage and whether really cytokine helps in cytokines are involved in the septic shock pathology, and does are cytokines removed by Cytosorb? The first animal models which were done by published animal model studies were published in Critical Medicine 2008. Basically showing rats which were underwent cecal ligation followed by perforation to induce septicemia, and subsequently after 20 hours they underwent 3 hours of Cytosorb filtration versus a subgroup of rats which did not undergo it. So it was clearly shown that as time went on, with time the TNF alpha, you can see very clearly this is the 0 hour is the time after starting hemoadsorption with cytosorb. Significant drop in that inflammatory mediators like TNF alpha, IL-6, IL-10, and IL interleukin 1 beta. So cytokines, the 3 hours that cytokines the cytosorb was used, significant reduction was done, and in that reduction also maintained at end of 9 hours. So my marginal increase, but the maintenance of hypercytokinemia, reduction of hypercytokinemia was maintained even 9 hours after stopping the cytosorb. So this was a animal model of multiple rat models, which showed that sepsis leads to hypercytokinemia, and these are the cytokines involved. And cytosorb can absorb the cytokines, and there could be a prolonged period of controlling of cytokines, and which will ultimately lead to improvement in hyperinflammation. Coming to the rat levels, to the human levels, basically this is a retrospective investigator-initiated study, in which hemoadsorption with cytosorb showed a decreased mortality observed versus expected 28-day mortality in ICU patients with septic shock. This is not COVID, but septic shock. This was published in 2019, in which two subgroups were there: cytosorb with CRRT versus only CRRT. So the subgroup of patients with septic shock who received cytosorb and CRRT together had a significant drop in the 28-day all-cause mortality, while the ones which only received CRRT had a non-significant reduction in the mortality. When they combined, when difference in the mortality was noted as a that in cytosorb group 47% mortality, while in CRRT 51% mortality, which doesn't really look very different. It was basically analyzed, found that the cytosorb group had more patients who had more hypotension and patients with more lactate levels. So when these baseline parameters were statistically negated out, it was found there's a non-significant drop in the mortality, which was in the range of 19% when the baseline characteristics of the patients were equated, the cytosorb group and the cytosorb plus CRRT group. CRRT versus cytosorb plus CRRT, because the two subgroups had some mismatch in the initial stage in the initial baseline characteristics. So after removing those baseline characteristics by statistical analysis, the difference in mortality was 19%. So what are the this was septic shock. So what are the potential indications of COVID-19 patients? So we know cytosorb is a device which can work in multiple situations where hyperinflammation is the predominant pathogenesis of the disease or the deterioration. Talking from sepsis to polytrauma to burns, extensive burns, major surgeries, abdominal surgeries, coronary artery bypass surgeries with prolonged clamp times, severe acute pancreatitis, acute liver failures, patients on other life support systems where cytokinemias do happen. And in today's day, talking of influenza, SARS-CoV-2, and the ARDS. So this is a myriad conditions where cytokinemias or cytokine storms happen, and cytosorb can be a life-saving in many of these situations if started on time. So we call it the Trinity of COVID-19, the trinity of immunity, inflammation, and intervention. As Professor Suranjit talked about the immunity, the normal immunity in which the virus would be attacked by the neutralizing antibodies and then removed by the present macrophages. And the macrophage, along with the CD8 cells, will also kill the dead cells or the apoptotic cells, which in which the virus will be multiplying. So this is the natural mechanism which normally occurs in a healthy immune response. The infected cells are rapidly cleared by the antibodies and the CD8 cell as well as macrophages. And this is what we see in mostly in 80% of the cases. However, there is some group of patients who, as I told you, land up in this hyperinflammatory syndrome for some unknown reasons, and which there is a dysfunctional immune response leading to excessive infiltration of the mononuclear cells, the monocyte, macrophages, and T cells, and which leads to what we call as the cytokine storm, in which a significant rise of IL-6, IL-10, and other inflammatory mediators like TNF alpha all are significantly raised. And this is what is an hyperinflammatory response, or which is called a cytokine storm. A subgroup of the patients land up in this situation, and And few of this, if not taken care properly, will end up on a ventilator, multi-organ dysfunction, and ultimately death. So the third part of the trinity is immunity, inflammation. So we have seen the immunity, we have seen the inflammation. Now what is the intervention? So this is the trinity, the three things which we should know in COVID-19. So the immunity we saw, the natural immunity, the innate immunity, and the adaptive immunity, which Professor talked about. The inflammation we saw, hyperinflammation in COVID-19 patients, which leads to cytokine storm. So what are the various mechanisms that we have? We know vaccinations. Number one, vaccinations or passive transfer of antibodies, which was plasma and monoclonal antibodies, which are now being available now. So this passive transfer of antibodies can neutralize the virus. They have to be started as early as possible, preferably in the first 5 days, and obviously not in a patient who is on oxygen or hospitalized for severe COVID-19. So this neutralizing antibodies will not work beyond a particular time. So 5 days to 7 days is the maximum time, and the patient should be relatively stable for these neutralizing antibodies to work. Second is blocking the TMPRS, which is basically which activates the spike protein of the virus. So there are protease inhibitors which can block this basically membrane protein, so that the virus spike protein is not activated and the virus can't bind to the ACE2 receptors. And there are some drugs which are being evaluated for this. Pfizer has a phase 1 trial on this drug. We may soon get one of these drugs. This will also be used in the early stages before the virus actively binds to all the cells. Third is what we all know, the innate immunity and the adaptive immunity, which comes in the CD4 cells, CD8 cells. The CD8 cells coming in, and so we could basically virus-specific effector CD cells, which are achieved through vaccinations. So this is the third way of intervening. The fourth way of intervening is basically removing the cytokines. This is where the late stage comes in. So in this situation, when the patient is presented to you in the hospital, in the ICU, it is basically hypercytokinemia. This is where you either give cytokine blocking or antibodies, or the IL-6 block antibodies, which receptor antibodies, which we are commonly using, the tocilizumab, or else the other option is to remove the cytokine by mechanical filtration. So the early stage is basically the stage where we use monoclonal antibodies, and late stages where we use cytokine filters or tocilizumab. Early 2020, when the virus or the pandemic was basically taking a shape, the respected critical care specialists like Claudio Ronco and John Louis Vincer already had indicated that new extracorporeal organ support therapies, including hemoadsorption and hemoperfusion, with new sorbent cartridge designed to remove cytokines and other circulating mediators, should be considered as a standard line of therapy in patients who deteriorate or admit in the hospital with worsening COVID-19 symptoms. So this was a way forward which they suggested. So Cytosorb belongs to the group of sorbent cartridge to remove cytokines. And it has already received the US FDA approval and the European Union approval, and also the approval in India. So we can use it in COVID-19 patients. And also being used in multiple centers or multiple countries like Italy, USA, Great Britain, Germany, so Colombia, multiple countries are already being used. More than 2,300 patients of COVID-19 worldwide have been till now treated with Cytosorb. So a large number of patients have been already treated. So that gives us some published data. So whatever published data we have, this is one of the published data in which it was Cytosorb was used along with ECMO in a patient from Germany, in which Cytosorb along with ECMO was used, and it showed significant reduction in the CRP levels, IL-6 levels, and the requirement of the norepinephrine, or the improvement in the vasoactive, or the improvement in the vasopressor requirement. So with ECMO, the patient given Cytosorb and showed a significant improvement in the cytokinemia. So really leading to a better hemodynamic stabilization. This was a case report from Turkey in which cytokine hemodabsorption of Cytosorb was used in a pregnant patient, near-term pregnant patient, and 3 Cytosorb devices were used on day 1, day 3, and day 6. And this patient could be continued despite having significantly raised TLC counts, raised LDH, significant raised D dimers, could be managed, and ultimately on day 7 cesarean section could be done and the patient could be saved. So the cytokine storm, despite being there, was easily managed with the Cytosorb, and gave the patient more time and to stabilize, and so that cesarean section could be performed. This was a severe COVID-19 pneumonia. Another case report from Italy in which they found that again in COVID-19, severe COVID-19 pneumonia in a patient whose Horowitz index, or what we call the PF ratios, pulmonary, the PaO2 FiO2 ratios, which was very showing severe ARDS picture with a PF ratios of less than 100, significantly improved after treating with Cytosorb, and the IL-6 level significantly dropped by day 10. So by day 10, IL-6 were actually in the negative range. I mean, and the patient had already recovered to a normal PF ratios. So a single center randomized control trial in Germany, in Hamburg, published recently in EISICEM, basically included patients with confirmed COVID-19 who were in shock, with requiring at least more than 0.2 microgram per kg per minute, with a documented IL-6 level of more than 500, and on any of the extracorporeal therapies, either ECMO, CRRT, or ECOR. So these patients' primary endpoint was to see stabilization of hemodynamics and shock reversal. And they found significant reduction in the IL-6 levels, in the procalcitonin, and the non-renal levels in this subgroup of in the RCT which they performed. A case series published from Saudi Arabia in which they used Cytosorb in patients with COVID-19 and AKI. So in critical ill patients, COVID-19 infection, pneumonia with AKI, they used renal replacement therapy along with the Cytosorb, and they found significant improvement in the urine output, the SOFA scores, the pulmonary, the PF ratios, and complete reduction in the vasopressor requirement after therapy in all the survivors. There were out of 50, there were 35 survivors and 15 non-survivors, which was a very good number. It was a retrospective case series. Another case report from Saudi Arabia, which showed 2 sessions of CRRT with Cytosorb. Patients, this was a case of COVID-19 presenting as an acute abdomen and sepsis, a rare case report, in which 2 sessions of CRRT with Cytosorb, we were able to initiate diuresis and venous vasopressors by day 3. Patient lactate levels and other inflammatory biomarkers were normalized. Oxygenation PF ratios improved to normalization on day 6. This was a case report on a patient with acute abdomen, which is a rare presentation in COVID-19. A case report from Italy of 4 patients in which tocilizumab versus tocilizumab with hemadsorption with Cytosorb was done. And all these patients found the IL-6 significantly remained elevated after tocilizumab. However, when they combined tocilizumab with hemadsorption, they found IL-6 levels significantly coming down after using hemadsorption. At the end of 7 days of tocilizumab, the IL-6 still remained elevated in the patients or the subgroup who had tocilizumab only, but it was less in the patients or the subgroup who had tocilizumab plus hemadsorption. Both the treatments were well tolerated, and all the patients were discharged home after some weeks. This was the international experience. Now, my experience I will be sharing with not only with COVID-19, but what we have a presentation on septic shock and sepsis. This was published in the World Journal of Critical Care Medicine last year, and this year January. The publication was, and this was the only prospective multi-center investigator-initiated study. Unfortunately, we don't have randomized control study till as yet, but this was as near as possible at the present moment context. It was a prospective study. It was a multi-center study and investigator-initiated study to evaluate Cytosorb or hemadsorption in septic shock in patients admitted to tertiary care units over a period of 2 years, 2016 to 2018. And it was a common protocol of treatment, and all the patients, all the centers received ethics committee approval. And you can see the baseline characteristics were mostly same, except that the predicted Apache scores in the survivors was slightly lower than the non-survivors. However, if you see that the leukocytosis was more in the survivors, initial leukocytosis, and lactates also significant was more in the survivor group. Initial lactate levels and initial leukocyte counts were higher in the survivor groups than the non-survivor groups. So what we found as a result of this, our multi-center prospective investigative initiative study, the survival group, 17 patients out of all the patients who survived, 2/3 received Cytosorb within 48 hours of ICU admission. This was the clinically significant. So out of the 45 patients, total 26 patients survived. Out of the 45 patients were included, but only ultimately analysis was done of 42 patients, out of which 2/3 survived, which was a very good number. And out of this 2/3, we found that the two survivors, 2/3 of who survived were actually got Cytosorb within the first 48 hours. While in the non-survivor group found only 38%, then 31% received Cytosorb in the first 48 hours. So 1/3 received the Cytosorb in the first 48 hours. So this led us to conclude that Cytosorb used in patients with cytokinemia with organ dysfunction should be used early as possible from the ICU admission to 48 hours. The later we use, we will not achieve any good results or any proper results as per our expectations. This was what came out of the study. You can see the Cytosorb in the survivors and non-survivors. All the patients significantly had a drop in the Apache scores and SOFA scores in the survivor groups. The vasopressors requirement came down significantly, and all the survivors had significant drop in the IL-6 levels, so which we were monitoring from 130 and 231 to 403. It was not a significant value, but it was a drop in the IL-6 levels, showing that cytokinemia was reduced. So the conclusion was that we observed survival outcome was better in patients where Cytosorb was used within 48 hours of septic shock, and chances of survival decrease with delay in initiation of Cytosorb therapy. Coming to case presentation in COVID-19, so we had this cases, 3 cases which I will be presenting very shortly. I'll present it. So this is a 61-year-old male post-renal transplant with a history of uncontrolled diabetic hypertension and was admitted to COVID-19. Also had oliguria and complete burning micturition. We don't know whether it was urosepsis. Cultures never came positive, but also had a oliguria, came with hypotension, metabolic acidosis, and severe respiratory distress. He was obviously put on meropenem, antiviral retroviral remdesivir, heparin as a standard care of therapy. Significantly high lactate levels, 8.4. Because of his respiratory distress, he was intubated on admission and also started on sustained low efficiency dialysis when the creatinine started going up to 2.7. And also he required vasopressor therapy of up to 10 mics noradline to make a map of 60. CRP was at initial CRP was 84.3. Two cycles of Cytosorb or 2 Cytocorp devices were performed, and this patient showed improved hemodynamics, improved ABG, lactate came down from 8.4 to 3.2. Creatinine improved, though some part of the creatinine definitely improved because of the SLED. There was window ventilation, and the CRP reports came down significantly, down from 84 to 43. And patient condition improved, and subsequently was discharged in hemodynamic stable condition. The second patient was a 56-year-old male who was admitted with fever and productive cough, and also had burning in urine. He also had multiple comorbidities, diabetic, hypertensive, previous history of had an recent AKI with secondary to obstructive uropathy, and also had pyelonephritis of the previous history, and BPH, benign prostatic hypertrophy. He was on 15 liters on oxygen on admission, and also received remdesivir, meropenem, steroids, anticoagulation, other support systems which we give for COVID-19. And obviously for worsening hypoxia, he was mechanically ventilated. He had significant raised procalcitonin, so there was a secondary sepsis in this patient. And the CRP was not significantly elevated because he had received steroids outside. So steroids probably kept the CRP under control, but IL-6 was moderately elevated. His creatinine also had jumped to 4.6, and he is also started one lactate of the 5.4 and a D-dimer, very high of D-dimer. Our normal levels are 500. For him, it was 2,600. He was started on norepinephrine, 5 mics per mg per hour. So he again a patient with COVID-19 and suspected septic shock with organ dysfunction. Again, 2 cycles or 2 Cytosorb devices were used without anticoagulation in conjunction with SLED, and significant improvement in all the parameters. You could see decreased D-dimer level from 2,600 to 927. Hemodynamics improved, hypoxia improved, lactate came down from 5.4 to 2.1. This labs are at the end of second Cytosorb filter. And the ventilator was subsequently weaned off, and the patient improved output on day 7 to day 14, progressively improved output and discharge in a stable condition. He is not requiring dialysis right now. Other was a moderate, relatively young male presenting to the emergency on very recently on 7th May this year, with fever saturating on 89% on 10-liter oxygen, breathless on examination, and positive for RT-PCR. Patient was relatively well. I mean, we were thought we will be able to, young guy would be able to manage with oxygen therapy only, with proning oxygen therapy and other treatment for COVID-19. He was even given a tocilizumab, steroid tocilizumab, all were given to him, including antibiotics, meropenem. However, he continued to worsen after a week and had to be put on a ventilator. Significant levels of IL-6 were raised at that time, found to be to 409. D-dimer was very high, again indicating systemic inflammatory response syndrome, 6,000 plus D-dimers. And on ventilator, his heart rate continuously kept on increasing to 140, sometimes went to 150, 160, indicating some sort of a myocardial dysfunction setting in. And at that time, the blood pressure dropped to 90/60. So with 90/60 VP and 2.6 lactate, it was basically a shock, COVID-19 induced shock with hypercytokainemia in the form of IL-6. So this patient also was performed two cycles, and there was significant improvement in the ABG. Lactates came down from 2.6 to 0.7. IL-6 came down from 409 to 1.2. CRP reduced. D-dimers came down very significantly to 590 after second cycle. Cardiac function, heart rate came down to 115. Breathing improved, VP improved, and the ventilator was weaned off. However, we could not completely wean off the ventilator because of his progressive lung fibrosis. He is still in the ICU on lung fibrosis, but gradually, progressively getting better. But he remains absolutely stable hemodynamically. Presently, only one organ dysfunction, that is the lung, and we are gradually weaning the ventilator. We are hoping soon he will be on tracheostomy and a tracheostomy with my minimal support. And this is the overview of the therapies which are present in published in literature till now, till December 2020. Few RCTs, few case series with control groups, and few all this showing basically inflammatory mediators improving, and hemodynamic stabilization, and improvement respiratory functions, and some case series without control group in which all showing inflammatory mediators improving, hemodynamic stabilization, most of them, and improvement of respiratory function in all of them. So this is what we have the published literature till now of Cytosorb. So in key message is Cytosorb is a life-sustaining and helped in attenuating the inflammatory response in both critical situation of the patient, regaining controlling of the cytosol storm in the context of COVID-19. Also, it can successful management of bacterial sepsis. What is important is early identification of cytokine storm, and early initiation of therapy reduces mortality. So this is where the doctor or the clinician or bedside or the intensivist come in the picture to know when the cytokine storm is worsening. That is the time when you initiate a Cytosorb or hemoadsorption device. How it is going to be too difficult to salvage the patient if the patient is already in multi-organ dysfunction therapy. Selecting the right patient, the right time, and the right amount of therapy will lead to better clinical outcomes. Thank you.
That is a nice thank you slide, Rajiv.
Thank you, yeah, ma'am.
Yeah. Before moving on to the introduction of the third speaker, I would like to remind you again, please drop your questions indicating the speaker that you want to ask the question from to the question and answer box on your screen. So we'll move on to the third speaker, having listened to the very interesting 3 cases that Dr. Rajiv has managed with Cytosorb, to Miss Bianca Filipoiu. She's from Romania. She currently works as the main application specialist for Cytosorbents Europe. She's leading the team about as the application therapist and specialist for Cytosorbent Europe at this minute. She's an expert on more various types of extracorporeal purification methods for critically ill patients. So may I invite Bianca to do her presentation on cytokine clearance by Cytosorb setup and handling situations in COVID-19.
Thank you so much. Thank you so much. So my job from now on is to introduce you a little bit in the practical situation and in the practical aspects of Cytosorb treatment. So basically how we start the therapy, what we should follow during the treatment, and when do you know that the treatment must be stopped or the treatment is effective. So first of all, what is Cytosorb? So Cytosorb is an adsorber. It's composed by highly biocompatible polymer beads inside, and those beads have the capacity of adsorbing substances inside of them. So basically, this adsorber, Cytosorb, it's working with whole blood. We don't need to separate blood or to do another kind of process before having adsorption inside of those polymer beads. What do you know about Cytosorb? Well, Cytosorb, it's not a new product. Actually, it has a little bit of history, more than 10 years on the market. That means more than 131,000 treatments, not only in one country, but in more than, I think, 68 countries right now, but numbers are changing quite fast. And everything happened in more than 800 clinical departments. In regards of treating COVID-19 patients, we have experience of more than 5,750 patients treated with Cytosorb. Treatment of 24 hours together with Cytosorb and all other platforms available in the hospital. And the show goes on because Cytosorb therapy it's developing day by day, and the spectrum of indication is increasing once we have more and more treatments. So first of all, Cytosorb, it's not a filter. That's a very important thing. So normally we have filters in ICU. We are used to use filters, dialysis filter, hemofiltration, and we are doing with those filters filtration, diffusion, or convection, or combination of those 2-3 processes for kidney function, for sustaining the kidney function, for treating kidney failure, acute or chronic kidney failure. What Cytosorb is, it's an adsorber. We don't have a membrane inside of Cytosorb. I told you we have polymer beads. And those polymer beads, they are able to do adsorption. That's the only physical process which occurs inside of the beads. Adsorption of cytokines, of inflammatory mediators, of bilirubin and myoglobin, but also adsorption of ticagrelor and rivaroxaban. If we have a patient, for example, which is under one of those treatments and has to go for an emergency surgery and the risk of bleeding is really, really high, we can use Cytosorb for reducing the risk of bleeding by removing those drugs from the blood. So Cytosorb, it's not a filter. And a big difference between dialysis filter, whatever it will be, that filter, and Cytosorb, it's the surface. So Cytosorb has a surface, if we will measure all those beads, which is around 45,000 square meters. And if we are comparing this surface with the surface of a filter, which is roughly 2 square meters, the difference is huge. So basically inside of Cytosorb, we have a kind of 4 sucker fields of adsorption available for removing substances from the blood. Another important thing related with Cytosorb is that this column is able to absorb substances with molecular weight less than 55, 60 kilodaltons, no more than that, because it's really, really important to keep albumin inside of the blood, and the albumin has a molecular weight of 64, 65 kilodaltons. And Cytosorb does not affect the level of albumin. Another important thing is that Cytosorb removes mainly hydrophobic substances. So those substances targeted by Cytosorb are not the same ones which are targeted by CRRT or by hemodialysis, but the other ones which are not soluble in water. Cytosorb doesn't remove substances which are not elevated as concentration in the blood. That means that with Cytosorb, you never remove something which is normal to be found in the blood. So for example, if you have in front of you a patient which has no elevated level of interleukin-6, you won't see a removal of interleukin-6. Or if you have two patients, one of them has liver failure and has a high level of bilirubin, and the other one is a septic one, but without a liver failure, and the bilirubin level is normal. You won't see a removal of bilirubin in case of patient which has not an elevated concentration of that substance, but a very important removal of bilirubin in case of patient which has a high level of bilirubin because has an acute liver failure. And because of course we are dealing with patients with high hemodynamic instability, we don't want to have too much blood in the extracorporeal circuit, so the volume of Cytosorb is just 150 mils of blood. That shouldn't be a risk or an additional risk for the hemodynamic of the patient. Cytosorb, I told you already, doesn't remove albumin. Okay, we saw in the lab a little part of albumin removed, but since that molecule of albumin that we found it in the lab, it's the molecule dehydrated. So basically the molecular weight is less than 60 kilodaltons and could be removed by Cytosorb, but that is not an active molecule into the blood. Also, Cytosorb doesn't remove coagulation factors and immunoglobulins. That makes it really, really a good product to be used in a different clinical situation with no risk, no activation of coagulation or complement system after Cytosorb treatment. That's a very, very good thing, especially because we are dealing with patients which already have coagulation activation or complement activation, and we don't need an additional pressure on those two. No complete removal of physiological mediators. Remember, I told you already that Cytosorb removes just what is elevated as concentration in the blood, not which is normally concentrated. But of course, because it's an extracorporeal therapy and inside of Cytosorb, there is a mechanical destruction of thrombocytes, you can see a low removal of platelets, but it's not something significantly, it's not something which needs transfusion or additional measures. It's comparable with what happens in hemodialysis. So those being said, we can say that Cytosorb is a safe therapy and has no risk for our patients. Okay, let's see which are the substances removed by Cytosorb. Well, Cytosorb removes cytokines, pro-inflammatory and anti-inflammatory, high elevated levels of cytokines, because both pro and anti-inflammatory cytokines are toxic if they are in high levels. Cytosorb removes DAMs and PAMs, so the triggers of inflammation, some bacterial toxins, bilirubin, bile acids, and ammonia. And we have experience from the field, from customers like you, using Cytosorb in treating liver failure with very, very good results and very good outcome for their patients. Cytosorb removes also myoglobin. That means that if you have in front of you a patient with crash syndrome, or a patient with rhabdomyolysis, or a patient which had a trauma, you can use Cytosorb for removing myoglobin and preventing the damage over the kidneys. Another important thing is plasma-free hemoglobin, which is removed by Cytosorb. So that's a big help also for the cardiovascular patients, preventing TRALI. And rivaroxaban and ticagrelor, Cytosorb removes those drugs, so can be used to prevent the risk of bleeding for those patients. So basically, Cytosorb has the purpose to modulate the immune response, to regain the balance, but not to shut down the immunity. So never we won't see a patient after a Cytosorb treatment going to immunosuppression. That's not an option after Cytosorb treatment. So let's regain control for our patients. Which kind of patient? The king of the king is, of course, the patient with sepsis. Cytosorb has plenty of experience treating those patients with sepsis, but not only those ones, but also trauma patients, patients with postoperative vasoplegia, for example, cardiovascular patients with rhabdomyolysis and trauma, patients with acute liver failure or acute and chronic liver failure, patients with pancreatitis, with influenza, patients with toxic shock, patients with hemophagocytic lymphohistiocytosis, patients with important burns, and of course, patients with COVID. So as any kind of therapy, Cytosorb has some contraindications. Some of them are relative ones. The other one are total contraindication. But let's see when we have to think twice before starting Cytosorb treatment. So the relative contraindications are patients in acute cycle cell crisis, patients which are under immunosuppressive therapy, and in those cases, maybe it's a good idea to increase the dose of immunosuppressive drugs, of course, and patients who are or might be pregnant. So in this case, we have to think twice, and we have to analyze the balance risk benefits and to take the best decisions. But total contraindications for Cytosorb treatment are patients with heparin-induced thrombocytopenia when we cannot start a citrate anticoagulation for those patients. So basically, we can treat patients with heparin-induced thrombocytopenia only if we can anticoagulate those patients using citrate, because Cytosorb can be used only with anticoagulated blood, with heparin or citrate. Nothing else is recommended to be used as anticoagulant. And another contraindication is thrombocytopenia when the thrombocyte platelets level is less than 20,000. So we have some recommendation about when not to start the therapy, but when to start the therapy. So our general recommendation regarding critical patients for initiating the therapy are the next one. So basically, we have two kinds of approaches. It's an early initiation of the therapy when our patient has shock, has a vasopressor administration, continuous, has lactate over 2 millimoles per liter, and in this moment requires advanced hemodynamic monitorization, requires ventilation, but the patient has not developed yet renal failure, so the need for CRRT or for hemodialysis, it's not there yet, but we can start here Cytosorb treatment as a hemoperfusion treatment, as a standalone therapy, and we can prevent the complication. This is what we found from the field, from the studies, from the case reports, from the case series. We have it from the field that early initiation of Cytosorb treatment is associated with a better outcome, with improving of clinical situation faster than waiting till the patient is already in refractory septic or vasoplegic shock. But to be honest, the majority of the patients treated with Cytosorb, they are in the last category. So they have refractory septic or vasoplegic shock with high demand of catecholamines. For example, noradrenaline is more than 0.3 picogram per kilo per minute. They have capillary leakage with an extravascular lung water index over 10 milliliters per kilo. Lactate is increasing and increasing. And if it's possible to measure IL-6 and it's above 500 picogram per milliliter, that's a good sign, because you have to, that's a bad sign, and you have to start Cytosorb treatment. Or if you're not able to measure IL-6, there is no tragedy, because we can consider procalcitonin. So when you have a procalcitonin above 3, you can think to start Cytosorb treatment as soon as possible. And of course, you have to be able to initiate the session of Cytosorb together with a CRRT, ECMO, or hemoperfusion platform. But what about COVID patients? So when everything started with COVID, and that story started to increase, and all the patients went to ICU, we said, look, we have experience in treating patients with ARDS. That was for sure. We have experience in treating patients with hyperinflammation and cytokine storm. Even we had experience with treating patients with hemophagocytic lymphohistiocytosis, which seems to be quite similar from the level of inflammation with COVID-19. So, for those patients with COVID, Cytosorb, it was an option, very good one actually. And we have some data coming from the countries which are using Cytosorb. So basically in China, they start Cytosorb treatment when the oxygenation index is between 100 and 150 millimeters mercury, and that is happening together with an antiviral treatment, and of course with supportive treatment. The Italian doctors, they're starting the treatment for patients with dialysis, or for patients with kidney transplantation, when the patient is in AKI stage 3 and should receive hemofiltration, and it's used for 48 hours in sessions of 24 hours, together with all supportive therapies. More than that, Panama has also some guidelines for starting the therapy with Cytosorb in treating COVID-19 patients, and they are targeting patients with refractory vasoplegic shock, with high ventilatory support needs, and patients who are under ECMO or extra life support therapies platforms. Again, 24 hours treatment in the first 6 hours to first 24 hours initiation of the treatment. But based on the experience on the field, Cytosorb can be applied also in case of the patient with profound vasoplegia, with elevated level of lactate and high need of vasopressors, patients with moderate ARDS, with an oxygenation index between 100 and 200 millimeters mercury. Also patients which are under ECMO treatment, because we know ECMO can trigger hyperinflammation, and patients with positive H score, because as I said before, hyperinflammation from COVID-19 patients, it's really similar with the one found in patients with hemophagocytic lymphohistiocytosis. So after we initiated the treatment with Cytosorb, we have to see what's happening in the next 12 to 24 hours, because we are dealing with high hyperinflammation, with a very aggressive one actually. We recommend in case of patients with COVID to change the first adsorber, only the first one, after 12 hours, and the next ones can last for 24 hours. And then we will evaluate again the patient in day 2, in day 3, to be sure that there is need or not need of continuing Cytosorb treatment. So first one 12 hours, the next one 24 hours without any problems. When we are deciding to stop the therapy, that's a very good question. So for example, we have a patient with ARDS and we are starting Cytosorb treatment. First one, of course, we are talking about COVID patients again. First one exchange after 12 hours, the next ones after 24 hours, and we will reevaluate the patient in day 2 and 3 to see if we are going to use another session of Cytosorb or not. Normally, the average number of treatments with Cytosorb is 3, because in this way we can be sure that we remove enough cytokines in order to regain the balance and to reduce the cytokine storm complexity. If we have a patient with refractory vasoplegic shock, again, and of course COVID, 12 hours treatment, first adsorber, then 12 to 24 hours, we have to see, because if it's something If it's a clinical status, which is not in the first 24 hours, but it's for 3 days, so 4 days, it might need more than one adsorber exchange or in the first 12 hours, because the concentration of cytokines is really, really high, and because the absorption process it's one based of concentration, we want to remove as much as possible from the very beginning. So of course, Cytosorb will remove high level of concentrated substances, and then if the beads are saturated, there is no therapeutical efficiency. Therefore, we have to change a new one after 12 hours to be sure that we have the best capacity of absorption for our patients. And we have to continue till the reversibility of the shock. So basically, Cytosorb is triggering the capillary leakage, the refractory hypotension, the microcirculation disorders, and of course the septic cardiomyopathy. And the effects are reducing the capillary leakage, improvement of cardiac function, improvement of microcirculation, and of course, because we have a cardiac output decent one, I would say, we can reduce also the need of vasopressors. So the aim of Cytosorb treatment is hemodynamic stabilization with shock control or shock reversibility, if it's possible. Let's talk a little bit about how to integrate Cytosorb in what you have available in your hospital, in the platforms from the field. So Cytosorb is a treatment which can be run as hemoperfusion, so as a standalone therapy, as CRT treatment with integration in all CRT platforms, together with CBP for cardiovascular patients, with ECMO in 2 ways, passive or active integration, but also if you don't have available none of the platforms described below, Cytosorb can run also with intermittent hemodialysis machines in 6 hours treatments or prolonged treatments like SLED, 8 to 12 hours. Or if you have a machine available to do hemoperfusion, you can run Cytosorb treatment for 12 hours and to continue the cycle till 24 hours without any problem. Important things regarding the treatment is blood flow through Cytosorb should be between 100 and 700 mL per minute. Of course, this this value 700 is only for ECMO and CPB. We cannot reach this flow on CRT or on hemodialysis, and anticoagulation. So before starting the treatment, we should have a look on our patient. If they are under lipidic nutrition, please stop the lipidic nutrition 2 hours prior starting Cytosorb treatment, and you can run again your lipidic nutrition after the Cytosorb treatment is finished. Because if we use both in the same time, we will have those lipids inside of the beads, and basically the efficiency of Cytosorb is 0 because everything is removed there. Vascular access, it's again really, really important also in patients with COVID. We want to have a flow through Cytosorb between 150 to 250 mL per minute, and anticoagulation. It's crucial when we are talking about COVID patients. Please keep the APTT close to 80 seconds if you are using heparin, of course, and if you can go for citrate, please go for citrate because it's much better. So basically, vascular access is really important. We saw in COVID patients that having a femoral catheter, it's associated with less coagulation and less alarms, of course. And if we are talking about anticoagulation, please keep everything close to the high level of the interval, so close to 80 seconds. Please take care also about the drugs you use during the therapy. So you have to have the same adjustment like you do basically in CRT, with one mention in addition, Vancomycin is actively removed by Cytosorb, unintentionally, of course, but it's a fact. So basically, if you cannot measure the plasmatic concentration of vancomycin, please give to your patient an additional gram of vancomycin when you initiate the treatment, and then you can follow your normal scheme of treatment. So Cytosorb can be integrated in any kind of machine available on the market, and can run in any kind of treatment. So we can have it as hemoperfusion without any kind of filter, as a standalone therapy when we want an early initiation of the treatment. We can use it in pre-filter integration when we are talking about Fresenius, when we are talking about Aquarius machine, about Infomed, about Nikiso machine, about B Brown machine. It's a pre-filter integration. So basically, after the priming, we will connect Cytosorb to the arterial line of the filter, and then we will connect the filter from the dialysis. If we have in front of you a Baxter machine, a Prismaflex, you'll need a post-filter integration of Cytosorb. The difference between pre-filter and post-filter, it's none regarding the therapeutical efficiency. It's just a matter of how the CRRT sets are developed. So no difference from the medical outcome, from the clinical outcome. Can be used together with ECMO as a passive solution or as an active solution. Passive solution means we don't have an active pump to take blood from the ECMO circuit and to go through Cytosorb. So we will use just the difference of pressure. We will take the blood and we'll bring it in Cytosorb after the pump, as you can see here, and we will deliver back the blood to the patient before the pump. Of course, if the patient requires a CRRT or a hemodialysis treatment, we can integrate Cytosorb on CRRT or hemodialysis, and together with those platforms, we can connect to the ECMO circuit, as we can see here in the pictures. But not everywhere it's available a CRRT machine or an ECMO machine, so we can use an intermittent hemodialysis machine. The integration is before the filter, and we have treatments of 6 hours or of 24 hours, only hemoperfusion, and only with 2 machines from Fresenius, to 4008 and 5008, because they are able to do hemoperfusion. The other ones like B Brown, like Gambro, like Nikiso, they are not able to do more than 6-hour treatments. So basically, usually you are using those treatments in 4 or 6-hour sessions. Please do not prolong those sessions more than that just because you have Cytosorb, because Cytosorb can be used for 24 hours, but the risk of using a hemodialysis treatment longer than 6 hours is increased, of course, and we don't want to have risk in your patient just because you have Cytosorb. So keep the same routine as usual by treating your patient. All the integration of Cytosorb, of course, for all of them, you can have our help, but we have videos which can support you to connect and to integrate Cytosorb in the circuit. So they are able to be downloaded from our website, from the YouTube, or of course, I encourage you to call us when you have questions or need of support. What not to do? Well, it's important when you do the priming to pay attention to a few really small things, but really important. The first one is during the priming, because Cytosorb requires a gravitational priming, is not to bring air into the adsorber, because if you'll have air on the lines before connecting them to the adsorber, then you'll bring air into, and the things look like this. And of course, when you have air, you have islands of nothing, because all those beads they are not able to absorb a thing, of course, because they are dried and they have to be wet to be able to absorb, and the risk of having coagulation in those areas, it's really high. So if you will connect your patient with an adsorber looking like this, you'll have these small spots like here when you have air. So basically, you're reducing the capacity of adsorption of Cytosorb, but in the same time, you are increasing the risk of coagulation. So all the time, follow the steps. This is how it looks. I'm sorry, the picture is not really good, but somehow just to have an idea, using Cytosorb together with lipid nutrition, lipids are going directly into the adsorber, so you will have absorption of lipids and a blockage of the adsorber because it will become saturated really, really fast. And here it's something related directly with the patients with COVID. So if the patient with COVID is not well anticoagulated, and we know very well that they have a high tendency of hypercoagulability. So basically, if you are not using enough heparin to anticoagulate them, you can have a lot of troubles, of course. But the precise thing here is those patients which were treated, who were treated with those two cartridges, they needed something for the thrombocytes, something from the platelets. So you might need, in case of some patients, to add an aggregation inhibitor just to be sure that you target all the phases of coagulation. In the beginning, there were some cases when they used citrate for anticoagulation of the extracorporeal circuits, heparin for systemic anticoagulation, and platelet aggregation inhibitor, just to be sure that everything goes well. Otherwise, we can see clots like these, big ones, and inside of the adsorber, same kind of clot. This is COVID patient, and this happened after a few hours of treatment. So anticoagulation is crucial when we are talking about COVID patients. Thank you so much. That was from my side. Looking forward to hearing your questions.
Thank you very much, Bianca, for your elaborate presentation. So we will move on to the question and answer session. There are like few questions. And there is a question about evidence for Cytosorb. Dr. Nilmini Vijayasuriya is asking, is there clear evidence to show that Cytosorb is beneficial in COVID? And another Dr. Paul.
Hello.
Hello. Did you hear
Yeah.
the question? Yeah.
No, I think your voice got cut off in between. I'm sorry.
All right. So is there clear evidence to show that Cytosorb is beneficial in COVID?
It's like this. I mean, it is already proven that Cytosorb is, I mean, the treatment for cytokine storm. And it is already proven that COVID, the cytokinemia and cytokine storm, raised IL-6, these are all been proven. So as a corollary, if there's a hyperinflammation and a product which is there which takes care of hyperinflammation, there's no reason to not to believe that it won't work. There's no randomized control trial. Obviously, you won't get a randomized control trial in such devices. I mean, especially with the pandemic going on. But there are enough case reports all over the world, and lot of published cases, and a lot of case series which are being published. With more experience, you will get more and more case reports coming up. You're not going to get a randomized trial, but maybe a prospective trial may soon come up. But the theory that hypercytokinemia is the cornerstone of worsening sepsis patients, and Cytosorb takes care of hypercytokinemia without causing immunosuppression. That's the most important thing which I want the audience to remember. Whether you give high dose steroids, whether you give tocilizumab, you are putting the risk of immunosuppression to the patient. And if you have closely followed Dr. Bianca's presentation, she clearly told that immunosuppression is not the which is not going to be induced by Cytosorb. So definitely there has to be potential benefit of this therapy. Only problem is that initiation of therapy. We should not be starting the therapy when it's too late. Vasoplegic shock, multi-organ disc failure, excessive capillary leak. That probably is a too late a condition to start cytosorb. But early stages, when the patient's worsening lactate, high raised procalcitonin, raised IL-6, yes, definitely it will work.
Thank you, Dr. Raj. Is Professor Suranjit with us?
Yes, I am
Yes,
on.
there is a question that are there any studies in UK to prove Cytosorb is effective?
So Vinodini, I think as Dr. Rajib mentioned, there are you have dexamethasone, you have tocilizumab, those have had big studies done. And then there are several other treatment options which you would not be able to do randomized studies as
Right.
you would do, etc. So I think the important thing is these are all important aspects of sort of managing the effects of COVID in a group of patients. Now, say you wouldn't consider this to be of very specific relevance to GPs, right? Because GPs would manage a different context. You all manage the really, really critically ill patients, and together with the other treatment options that are there, that is the sort of steroids, the tocilizumab, which definitely has immunosuppressive medication, but they have had trials because of the numbers that have been treated with this and randomized trial. So the important thing is that there are cohorts of patients who would need other treatment options, and that is the sort of category which you all will be seeing, who would be needing this treatment option to be considered. And as more trials come, as more studies come in, say case series together with sort of prospective studies, would provide the data going forward.
Thank you, Suranjit. Another question to first two speakers. Have you any experience of offering Cytosorb in patients who are on NIV or high flow nasal oxygen?
May I answer that?
Yeah,
Yes, please.
Yes.
This is a little tricky question, which I mean, NIV is a subjective treatment, basically an area where patients are basically may not be having, most won't be having evidence of other organ injury. They may be only the single organ injury, the PF ratios worsening, or the patient is in some sort of respiratory distress. This case, yes, would be a candidate if the patient's progressively hypoxemia is worsening or respiratory distress is worsening, and with a significantly raised IL-6. But only an IV patient is relatively stable, Cytosorb may not be the ideal option in this patient. But if the patient deteriorating and there's a possibility the patient may get ventilator in the next 12 to 24 hours, you're seeing a rapid deterioration in the PF ratios. So ARDS, only ARDS, yes, there is a indication of Cytosorb, but only NIV with no organ dysfunction, patient not worsening significantly, probably Cytosorb may not be at the present moment, not for use.
Right, thank you. Next question is also to Dr. Paul. Is asking, your presented cases have a high D dimers.
Yeah.
Did you use anticoagulants in these patients? If so, what anticoagulants did you use?
A good question. Basically, one good thing about COVID-19 treating patients is by default, COVID-19 being a prothrombotic disease, all these patients would be on some sort of anticoagulation before even we start of Cytosorb. All patients on COVID are on the enoxaparin or dalteparin, with actually the highest, the prophylactic dose, and some even the therapeutic doses of this. So fortunately, those patients which we use Cytosorb, we did not require anticoagulation. Probably we got saved because these patients were already having anticoagulation as a part of the routine treatment at higher doses. So we did not require anticoagulation in all these patients.
Another question, how long can you use one Cytosorb? Is it usually, whether usually 2 is enough?
Yes.
How
It
long
is,
can you use
yeah.
one Cytosorb?
Yeah, I understood, ma'am. The two question, part of the question. First part is how long. It's a little bit of clinical judgment. If the patient is in hypercytokinemia and patient deteriorating rapidly on vasopressor therapy, noradrenaline requirement is going up and urine output is dropping, lactate levels are climbing steadily, then as Madam Bianca presented, I mean, the first cytosorb most probably will be 12 hours. However, the second cytosorb will be generally after the subsequent cytosorbs filters will be 24 hours. So if rapid deteriorating patient, 12 hours is the time when you change the cytosorb device. And how many to use is a very subjective term, but mostly the studies that we have we have published and we have gone through, averaging cytosorb filters would be on around 2 to 2.5. The average of 2 to 2.5 filters per patient is what's the average which comes out to be. I mean, there are instances of one patient requiring 7 filters, but those are exceptional cases. But average of 2 to 2.5 filters is what we call as an average. So first filter 12 hours if the patient is very critically ill and worsening, subsequently 24 hours for each filter. Preferably no gap in between, and a gap of 1 hour can be given, but continuation therapy is the best option. And second part of the steps of that question is sorry. So I'm sorry. How long is that? How long is, I mean, how many filters? Average, you can tell your patient most probably will requiring 2 filters.
Thank you. There is a question about cost. So it is asking what is the cost in Sri Lanka, but at least if you can say what is the cost in UK and India, then we can have some idea. I don't think any of you have any idea about the cost in Sri Lanka.
I don't think we'll have any difference in the cost in Sri Lanka and India. I mean, probably to this, except the exchange value, the cost will be. But to tell you the cost in India, I mean, for a device.
So I get an answer here. In Sri Lanka, 315,000 per filter, per unit.
Okay, that works out to be Indian currency. It comes to 95,000 Indian rupees per filter. That's what the present cost is in India. So,
right. The next question is to Bianca. It's asking, can we use Cytosorb without using CRRT or ECMO?
Yes, we can use Cytosorb in intermittent hemodialysis machines, in SLED machines, but also in hemoperfusion machines and in CPB. So basically, Cytosorb can be integrated in any kind of platform which has a blood pump, because this is the minimum required by Cytosorb treatment. To have a blood pump and, of course, some blood lines, an arterial and a venous line, to be sure that you have all the setup. That's the minimum. So whatever you have available in the hospital and has a pump can be connected with Cytosorb.
Next question is also to Bianca. Please explain again where to connect in the ECMO circuit.
So in the ECMO circuit, we have two kinds of connections. The first one is a passive way. That means that we won't have an additional pump just for Cytosorb, just for the lines of Cytosorb. So we will take the blood from the ECMO circuit, from the port which is found after the blood pump, where the pressure is higher. We will go through Cytosorb, and then the return from the Cytosorb bypass, it will be before the pump, where the pressure is low. So basically, it's from the high pressure to the low pressure. That's the passive way. Another way of connecting is the active way. That means that we have an additional pump. That additional pump can be hemoperfusion machine, can be a hemodialysis, can be a CRT machine, which in the end, after connecting Cytosorb on that machine, we will connect all the system to the ECMO system, and basically Here we won't need to connect Cytosorb from the high pressure to the low pressure because we have the machine handling the pressures and circling the blood through Cytosorb, circulating the blood through Cytosorb.
I hope that answers that question. Next question is about the dose of heparin. I think Dr. Paul can answer that. What is the dose of heparin to be added
I think
to
this.
Cytosorb?
I think Bianca will be the better person to answer this.
Okay, Bianca, what is the
Yes,
dose of heparin to be added to Cytosorb?
normally it seems to be okay, the same dose like CRT as usually. So basically we need a bolus before connecting Cytosorb to be sure that APTT is on the therapeutic level. So usually in CRT we are using 20 to 40 units per kilo as bolus, and then a continuous infusion of heparin, which can be between 10 and 20 units per kilo, in order to maintain that APTT of above 60, closer to 80 seconds if we are talking about COVID patients. But of course, it's everything related with your experience, it's everything related with your local protocol. So probably you can use low dose of heparin and you can have efficiency from the anticoagulation point of view of circuit, or higher dose, it depends. But normally 20 to 40 bolus, 10 to 20 units continuous.
So added to the same question, asking whether protamine can be added to the patient end. Bianca?
Yes, like in case of any extracorporeal therapy, you can anticoagulate just the circuit, and to be a local anticoagulation, not a systemic one. As long as in extracorporeal circuit APTT is close to 80 seconds, there is no risk for Cytosorb. You can do what you think necessarily to be done with your patient. That's absolutely fine. But in extracorporeal circuit, the blood should be anticoagulated. You can put heparin in your patient afterwards.
Next question to Dr. Paul. Is there, this is unrelated to this, I think, is there any benefit of nitric oxide therapy as a modulator of endothelial function in COVID-19?
If you go by the Society of Critical Care Medicine, US, it is very clearly recommended not to use inhaled nitric oxide in COVID-19 pneumonias. I mean, like any other ARDS, nitric oxide remains an experimental therapy in COVID. Could be used as a salvage therapy when all modalities of treatment are failing. You have nothing left to give to the patient. So as an experimental therapy, it could be used on a ventilator patient with refractory ARDS, where all your other modalities of treatment have failed. Routine use of inhaled nitric oxide is not recommended by any society right now.
In intubated patients, do you start the Cytosorb therapy immediately after?
Not like that. I mean, basically, intubation is one of the criteria. I mean, intubation is a single organ dysfunction, as I told you. If it is only a worsening PF ratios, hypoxia worsening, patient respiratory distress, we intubated. It's not that only RDS is the only criteria that we would look. If you intubate the patient, other organs, the kidneys, other organs are performing well, the lactate is not high. So basically, in such cases, we would like to wait for some time and see how the patient progresses. However, if the patient has evidence of other organ dysfunction, which is the typical what we call a cytokine storm affecting the systemic, causing systemic dysfunction, there definitely it will have a role. Only intubation for a worsening PF ratios, probably will wait and watch for the patient, give the continue the other other therapies for COVID-19, and we'll see for organ dysfunction or hyperlactatemia or worsening of the patient's condition before we go for Cytosorb.
I think that is the last question we have got. Professor Suranjit, are you with us?
Yes, I'm with you all.
Just one question from me. What is the, like, you saw evidence for remdesivir? You say you have any idea?
Yes, so remdesivir, I think I've done a small clip also on, sorry, remdesivir, not tocilizumab, sorry, remdesivir. So used early, it reduces, there have been quite a number of studies that have been done over the year, over the months, and it should be used early in the course, and we would use it. The mortality benefit is less clear as opposed to reduction in hospital stay, etc. But people would use it, but used early. I thought you were asking about tocilizumab. Sorry.
Yeah, you can go on and give your opinion on tocilizumab also. There was a
All right,
question
okay.
earlier which was
Okay,
taken
so
off, right?
there are the criteria we use are the NICE criteria, which have been clearly laid down. And I know one important thing for us to always remember with COVID is it's a developing field. I mean, that's very important because, you know, evidence will come, it will be refined, it will be further guideline changes will occur. So when it comes to tocilizumab, there are very clear criteria. Again, with regards to tocilizumab, which the NIH and the NICE have put forward, and we follow those guidelines with regards to they have to have had steroids because that was essential treatment option that they have to have. And as long as they don't have the contraindications, we would go and give tocilizumab. So I think it's just to follow that guideline, and then the guideline will be refined as more the evidence comes in. That's the take-home message there.
Thank you very much. We are reaching an end of the session. So I make this an opportunity to thank you on behalf of the President and the members of the College of Anesthesiologists Anesthesiologists and Intensivists of Sri Lanka and Faculty of Critical Care Medicine of the College. I must thank all three speakers for their excellent presentations and contributions to the question and answer session. So I make this an opportunity to thank Dr. Bimal Kudavidanage, who is the head of the Faculty of Critical Care Medicine of College of Anesthesiologists and Intensivists of Sri Lanka, for mediating and making this event possible. And also to Brigadier Professor Tamasi Makulolua, the president of our college. And as I told you earlier, our president and the president-elect are working voluntarily and opening up 2 intensive care units in one of the military hospitals of Sri Lanka and taking care of COVID patients. Therefore, they are unable to join these sessions. Then I thank again to all three speakers for the presentations and all the participants for their valuable participation and their participation in the question and answer session. Last but not least, I have to thank Cytosorb Europe for their kind sponsorship, and then the ABC Pharma for their local mediation and making this event a success. From ABC Pharma, Rajiv, our local coordinator, who has helped me by physically being with me here, and then Pradeep from India. Right. Thank you very much. We hope to meet you again with our 4th webinar in the webinar series organized by Faculty of Critical Care Medicine, College of Anesthesiologists and Intensivists of Sri Lanka. Thank you very much. Stay safe. Good night and have a good evening.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Bye-bye.